This is a mature brown cataract. After applying the superior rectus bridle suture, a fornix-based conjunctival peritomy is performed from 11 to 2 o'clock along the limbus, and tenoids is separated from the sclera. Bleeding vessels are cauterized for a bloodless operating field. For beginners, calipers can be used before making the scleral groove. A 6.5 mm scleral incision 2 to 3 mm from the limbus is made using a 15 number Bart-Parker knife. There are different kinds of scleral incision, out of which the most astigmatically neutral is the frown incision. Optimal incision depth is usually 2/3 the thickness of the sclera, or about 0.3 mm. A side port is made at 9 o'clock using a 15-degree stab blade. 0.1 ml of 0.1% trypan blue is used to stain the anterior capsule under air, as it is difficult to perform capsulorhexis in the absence of red reflex. Viscoelastic is injected in the anterior chamber before starting the capsulorhexis. The space maintenance ability of the viscoelastic, especially the cohesive type, keeps the anterior chamber formed despite the presence of multiple corneal incision. A small medial opening is made in the anterior capsule and a circular flap is raised. The flap is then directed counterclockwise to make a complete circular opening. A continuous curvilinear capsulorhexis is done using a 26-gauge cystitome or Utratas forceps. For dense cataracts, an opening of 6 to 6.5 mm is made. The wound construction should be such that the internal aspect of the tunnel is 25% larger than the external incision. The scleral pocket is constructed using a diamond crescent and anterior dissection is performed. The crescent should orient in an upward and forward direction to remain parallel to the sclera. At the lateral end of the tunnel, the knife is tilted sideways, creating a funnel-shaped tunnel of 45 degrees, thus extending the internal incision as compared to the external incision. A 2.8 mm microkeratome is introduced into the tunnel in an oscillating manner to avoid premature entry into the anterior chamber, and the inner corneal lip is extended. The direction of the keratome should always be lateral and anterior. By moving posteriorly, the valve action will be lost, causing wound leakage. Gentle multi-quadrant hydrodissection is attempted. The bag is decompressed if elevation and contact of the endonucleus against the capsular bag is seen during hydrodissection. Hydrodelineation is avoided. The capsule is retracted and a part of the nucleus is leveled out with a Sinskey hook. The nucleus is then gently wheeled out, watching the movement of the capsular bag throughout the procedure. Viscoelastic is injected above and below the nucleus to protect the endothelium and the capsular bag during nucleus delivery. The nucleus can be delivered out of the anterior chamber by hydroexpression, viscoexpression, rectus-assisted delivery, sandwich technique, fishhook technique, or Blumenthal technique. After nucleus delivery, the remaining cortical matter is washed with the irrigation aspiration Simcoe cannula. At every step, the anterior chamber should be well formed with viscoelastic. In this case, a polymethyl methacrylate non-foldable intraocular lens is inserted with fine-tip smooth forceps. The intraocular lens is advanced by placing the leading haptic into the bag and guiding the optic and trailing haptic into place. Viscoelastic is thoroughly washed. It is important to remove the viscoelastic, that is the dispersive type, completely to reduce the risk of an ocular hypertensive postoperative period caused by angle outflow obstruction. Conjunctiva is cauterized with bipolar cautery, and the side port is hydrated with balanced salt solution.